Folks, it is 11:01. I see a few more folks piling in, but I think we can just get started anyway. I want to introduce myself. My name is Gray Campbell. I am the Learning and Development Specialist here at 6 Degrees Health, and we are bringing you the Fireside Chat series. We started this back in 2020. We love it. It comes out once a month, and it is all about the self-funded industries, specifically healthcare and healthcare insurance. Today's Fireside Chat is called The Politics of Healthcare Repricing, halfway to November. We are featuring Ryan Work. I want to welcome Ryan Work. Welcome.
Thanks for having me.
Absolutely. We're super stoked to have you. We have Ryan Work with us. This is, I think, his third or fourth visit. I absolutely adore talking to Ryan. I love hearing what he has to say. But before we get there, I do want to introduce a couple more folks. We do have Heath Potter on the call. Heath, you should change your name. It says Lindsay Fleck, and you are not Lindsay Fleck today. You are Heath Potter. Heath Potter is our chief.
Everyone's messing with me. They tried to even keep me from joining this thing. So I'll come in as Lindsay if I have to. Just to be
We're glad to have you here. Heath Potter is our Chief Growth Officer at 6 Degrees Health. Welcome, Heath.
Thank you. Happy to be here.
And let's get right into our fireside chat. So on the next slide, we will see the agenda for today's chat. And oh, there it is, today's agenda. So the politics of healthcare pricing halfway to November. No Surprise Act. We're going to talk about the No Surprise Act, and we're going to specifically go into the process and protections of it. Then we're going to be learning more about transparency and coverage rule. You've heard a lot about this, folks, and we've got some RBP guidance for you. 6 Degrees Health is a cost containment company, and reference-based pricing is a big part of what we do. So we're going to talk a little bit about that. And then we're going to be getting into the prescription drug pricing. What's going on the Hill right now with prescription drug pricing, Ryan? We'll get into that. So again, I do want to mention Q&A. If you've got questions, we want to hear them. It's a huge part of what we do here. This is a fireside chat that has some questions that we've already come up with, but we want you to ask questions too. So please use the Q&A function if you'd like to chat with Lindsay Fleck, AKA Heath Potter, by the fireside there. He's going to monitor those for the second half of today's show. It is 1 hour long. Okay, so let's get into it. Ryan Work, everybody. Ryan Work is phenomenal. He works in Washington, D.C. for SIA, the Self-Insured Institute of America, and he is a lobbyist for SIA. Ryan's been with SIA for quite a while now, and he really does have a pulse on D.C., and I really want to talk about the mood up there on Capitol Hill, Ryan. What the heck is going on? We've got inflation. It's freaking everybody out. I know it's freaking me out. Gas prices are through the roof. There's a big midterm election coming. I really want to get a pulse as we open the show. Tell us from a self-insured crowd perspective, what's going on?
Well, I mean, we could talk about this for an hour, right? You mentioned gas prices. I mean, I had to fill up over the weekend at almost $5, and it's still like floored me, right? And you know, Charlie Cook last week said something interesting that stuck with me going into the election. He said, look, you know, about 6 to 7% of the country is unemployed right now, and unemployment's fairly low, but 100% of people are paying high gas prices and dealing with inflationary pressures. And you know, one of the things we're looking at from a political perspective, right, is how does that lead up to November? And as the months tick by, as we get closer to that first week in November, you know, it's going to be harder and harder to fix problems that the average American faces. And on top of that, I think one of the things that's changing in at least the campaign landscape is that you now have early voting and you have mail-in ballots. And as we have more mail-in ballots and early voting, that if you think about it, the timeline for candidates to fix problems and get their message across starts narrowing down, right? So now all of a sudden you go from campaigning to the, you know, all the way through the beginning of November to maybe actually having only until maybe the first week of September to actually get your message across, right? So you have all these things, and I always tell people, you've heard me say this before, that a lot can happen between any point in time in November, right? So whatever happens to inflation or gas prices, or for instance, baby formula. And today in Congress, one of their big focuses is a hearing on UFOs. So I mean, heck, who knows what's going on, right? But I'll also leave you with this in terms of like the political world right now, is that there's a number of factors that play election after election after election, and a couple of those have to do with the popularity of the president, and every single time midterm elections are a referendum, whether you like it or not, on the president, and especially when you have a unified government right now. And the president's popularity, if you look at all the polls, is not in a good place. I think really in modern times, the only president that's had more disapproval is Donald Trump. You look at the direction of the country, which is about a 32-point underwater gap right now, and you look at voter enthusiasm, right? You look at how enthusiastic voters are by party, and right now Republicans have like a plus 17 point advantage in that. Now that will change, and it has been changing. One of the things I just saw, which gives me a little pause too, is that a year ago, like young voters who largely were there to, for instance, like elect, Barack Obama in his first term, they were overwhelmingly, I think they were like around, I want to say like 60% like voter enthusiasm, and that's dropped by like 15 to 20 points in the course of the last couple of months. And so you just look at those different data factors and what they mean going into the election. And, if I had a crystal ball right now, I would say, look, the House is going to flip. The House is probably going to flip big. The Senate is a totally different battleground right now. And that's going to be really a tough, a tough crystal ball to look at, if you will. And today there's a bunch of primaries in states like Oregon, right? In Pennsylvania, just north of here, and in North Carolina. And folks are looking at all those different races, both in the Senate and House, because in both parties, Gray, you have incumbents facing challenges from either the right, if you're a Republican, or the left, if you're a Democrat. Like in Oregon, Kurt Schrader, who's a relatively moderate Democrat, is getting a primary opponent on the left, just like there's Republicans who are fighting in Pennsylvania for the Senate seat. I mean, you have two ultra conservative members of Congress, one being Dr. Oz, by the way, who are fighting for that primary. So as we go through this primary season, it'll set the stage come November. Yeah,
it seems like a tough time to be a moderate nowadays.
the moderate like bend is getting smaller and smaller and smaller, especially during the primary season.
Wild. Well, thank you, Ryan. I appreciate that synopsis. It's always good to kind of hear what's going on up there. And, folks, we are going to get specifically into these areas right now. I really want to start talking about the No Surprise Act. And so the No Surprise Acts, Ryan, I think giving people a little bit of perspective about this, quick overview, why this legislation happened, and recognizing that it's all about the practice of balance billing members. Give us some background here, Ryan.
Yeah, so I mean, I think if you look at the No Surprises Act, we were helping to craft that for several years before Congress came to that conclusion. And one of the things that policymakers were looking at were the constant kind of constituent complaints about receiving, going to a hospital, going to an emergency room, getting a major balance bill. And I think as more and more states sought to put in place protections, which are mostly for the fully insured plans, because obviously self-insured plans have ERISA protection. There was more of a challenge in Congress to do something about it. And so the No Surprises Act came from that, right? It came from the fact that more and more states were doing it, so they were feeling pressure on the federal level. I think that they were hearing more from constituents, and there was some big kind of research and investigative pieces that came out, and it kind of kept gaining momentum, along with just the fact that healthcare prices, as we all know in the industry, are going up and up, and how do you tackle that? And it ranged from anywhere to your ER visits to your air ambulance, where, there was a story of like a $15 million air ambulance bill. And all of a sudden, big stories like that, like those man bite dog stories, are what makes good or bad, is what makes Congress actually, do something about it finally. And that's what we saw with the No Surprises Act.
Well, let's take a look how it specifically, this law protects plan members, and providing some insight. Maybe specifically, Ryan, let's go back to that slide. Thanks. Take a look at that left column, everyone. I want you to see on the left column there, for plan years beginning 1/1/22, prohibits balance billing in certain cases. Specific cases, these three different types. Can you help us understand this, Ryan?
Yeah, so really balance billing, it covers three specific areas of surprise billing. So one is if you go to an ER, if it's out of network. I mean, the fact is, if you have an emergency, you're going to go to the closest CR. You don't care if it's in and out of network. So it covers those situations when a patient goes to an emergency room that's likely out of network. The second portion of that patient protection has to do, and I think this is probably the most egregious that we see with balance billing, is when you go to an in-network facility knowingly and say, hey, look, I'm just going to be charging the network rate, my deductible, but then come to find out after the fact that you have an ancillary service provider, like a radiologist or an anesthesiologist, radiologist, we call them wrappers, who then are not in network in that in-network facility, and then balance bill after the fact. So basically, a patient can now feel comfortable after January 1 of this year going to an in-network provider or a facility and knowing that they're just going to have to pay in-network rates for all the care they get, no matter who does it in that facility. And then the third, and I think it's important, is the air ambulance piece, right? Because we've seen egregious, especially out west, egregious air ambulance bills. And so part of the No Surprises Act protects those air ambulance services, from balance billing a patient $1, $2, $3, $15 million. And there's even talk from here to actually look at protecting ground ambulance, which I know a lot of our plan members have also kind of expressed some complaints about. Oh yeah, I'd love to see that. And so the way I see it is that there's a huge amount of consumer protection here, especially that second point there. I've been in a situation going to the hospital where I've had to pay much higher prices because of some out-of-network radiologist. And I had no idea why or how that occurred, but now we're giving some transparency into that, it sounds like. Right. Awesome. Yeah, and I think it's a lot of, it takes away a big point of confusion for consumers when it comes to healthcare, because I think, I think folks even in the industry get confused sometimes. It just shows the complexity of the system. But when you go to a network facility, like, okay, got it. I'm going to network doctor. This is all good. Then you get a balanced bill afterwards from, somebody who spent 5 minutes in the hospital with you, and you kind of question, well, where did this come from? Why am I paying this person $1,500? I thought it was all in network. So it takes away, at least to some extent, the confusion that patients have, right? Absolutely. Well, listen, let's start taking a look at the process. And I want to go into detail on the right part of this slide here, Ryan, and take a look at those first 2 points, points 1 and 2. Talk us through it. So for some reason, I'm actually not seeing the slide. So I'm just going to talk to you about the slide. So, you're good. Sorry. But so if you want to talk about the process, I mean, here's what it is, right? So that as soon as that healthcare customer, if you will, walks into one of those scenarios, right? So let's say, I'll use Heath as an example, or Lindsay in this case. So, Heath goes into an emergency room, for something, all of a sudden, has an emergency, goes in, gets taken care of, goes home. He is protected. He will get an in-network bill, in-network deductible for the services rendered. Then really, because this is what surprise billing is all about, this process, Gray, is what is the right reimbursement between the health plan or the employer in the self-insured case and the provider. And the whole process is about that reimbursement. What is the appropriate reimbursement mechanism for this? And so the whole federal process starts with the provider, the doctor, or the air ambulance company sending that initial bill, that initial claim to the insurer and starting the process. And so once the self-insured entity gets that bill, if you will, then they calculate something called like the QPA, the qualifying payment amount, that in-network median rate. And they can deny payment, or they can say, okay, well, this looks pretty good, we're going to go ahead and pay this, right? Which isn't probably likely, but it could happen. So there's kind of that initial, I guess, claim documentation and reaction through the process. That sets in place, I believe, like 30 business days. And once that happens, the likelihood of this happening is great. It will go to the second part of this process, which is the open negotiation period. And really, and again, this is another 30-day period. And I view this really as a 30 business day negotiation back and forth between the provider and the plan about, hey, look, the provider wants this, the plan's going to pay this. We're going to go back and forth until we come up with an appropriate reimbursement that is hopefully based on in-network median rates, based on past claims for that type of procedure within the region, on that QPA amount. So there's some benchmark that folks can base that off of. And so again, that can be that price that you negotiate can be, whatever you want it to be. But again, at the end of that 30 business day open negotiation period, if you don't come up with a price that is mutually agreeable to both parties, patient aside, then you enter that third and final phase, which is the federal arbitration independent resolution process.
And, I've always kind of wondered this, who are these certified arbitrators anyway?
Yeah. So I think it's important to understand what the federal arbitration process is, right? So one, after you end the open negotiation period, you enter arbitration. And the first thing you do, to your question, Gray, is you pick a federal arbiter. So I think your question is, well, what the heck is a federal arbiter?
Yeah.
Right? So the No Surprises Act basically outlines a number of things that a qualified federal arbiter can be. And it's an arbitration entity that has healthcare background, that understands claims, understands costs, and has a process and the knowledge in place to make an educated decision. And one of the things that we push for, which is also in the bill, is they can't have conflicts of interest. So they can't be owned, for instance, by 6 Degrees, or they can't be owned by a hospital provider. They have to be truly independent.
Okay.
And they basically apply to the federal agencies to be a certified federal arbitration entity. In the interim final rules, the federal departments thought that there would probably overall be about 30 certified entities. Now, realize each of these entities could have 100 different arbiters within them. But the federal agencies thought that they would have about 30. As of last week, up on the CMS website, there's only 10. And we can go into reasons for that. One of which is the low prices that arbitration costs and the complexity of it. But I think that there's some fear that there's few entities and there's going to be a lot of potential surprise billing claims.
Yeah.
So.
Well, listen, I have a lot more questions about this, but I do want to move on and talk about the transparency and coverage. I noticed we've got a few questions coming through the Q&A, so I want to make sure we get to those. So let's talk about transparency and coverage. A lot of information on this slide. I do want to kind of get into the fact that we've got self-insured plan stakeholders on the call, Ryan, and the transparency and coverage rule affects all of us. I want to get into the reference-based pricing guidance specifically, but before we dive too deep, let's talk about what happened in Colorado. I think it was yesterday. The Colorado Supreme Court had a ruling that really affects these RBP plans in Colorado. What happened, Ryan?
Yeah, no, it's actually really timely. So, what we've seen, and I'm sure 6 Degrees has seen to some extent, is you have hospital lawsuits in a number of states kind of pushing back on patient responsibility and even potential like RBP reimbursements. And, SCI has been very involved in pushing back against some of these provider lawsuits. So, to go to the Colorado case, and this decision just came out yesterday from the Colorado Supreme Court, it's a case called French versus Centura Health. Basically, this patient, her name was Melinda French, went in for what was supposed to be minor back surgery. I think the hospital looked at her insurance, and she had a self-insured plan that was under an RBP structure, and said to her it would probably cost, like, I believe it was like around $1,500. Okay, and she had it. She had the surgery, had some complications. Well, all of a sudden, you know, the price increased to all of a sudden the price increased to about $350,000. The RBP plan ended up reimbursing at about $78,000, and then Centura Health, in their infinite wisdom, decided that they would balance bill Melinda French for the remainder of that, claiming that when she first went to the hospital, she signed the agreement saying that she would be responsible for all charges.
Sure.
Centura Health thought that all charges also meant the charge master. Okay. And so about a year ago, a lower court sided with Centura Health that, you know, that she was responsible for that balance bill. It was appealed. We were an amicus brief on it. And yesterday, to your question, Gray, the Colorado Supreme Court came out and said, no, she's not responsible for it. You know, she had no ability nor knowledge of what that charge master was. And I think even more importantly, it allows, at least in the state of Colorado, that RBP structure and reimbursement to remain in place, you know, for basically what our view is for self-insured plans to be able to effectively manage costs and be, you know, and have opportunities around that. But there's one quote, and I don't have it in front of me, from the Chief Justice in Colorado that basically said, look, we as this Colorado Supreme Court think that charge masters are arbitrary. They're ridiculous. Nobody can understand them, nor should they have to. And so, you know, it was interesting, not only at the dig the court made about charge masters, which we all know is ridiculous. I think that they said that the woman would have had to look through 50,000 charge master codes to understand what that meant. But more importantly, it allows RBP to maintain in place in Colorado and to protect patients. So it was a very good, I think, court decision all around for self-insured plans for patients and for RBP as part of that.
Well, I did want to take us off topic, but certainly it's on topic. So thank you, Ryan, for that explanation. Good stuff, folks. And if you want to look at that yourself, again, what was the title? It's Centura Health versus.
Yeah, it's you can look up the French case. It's French versus Centura Health. Yeah,
that's right. Okay. Well, let's get back to the slideshow, Ryan. So looking at transparency and coverage rule with RBP guidance, can you explain the requirement? I'm reading this and I just want our audience to kind of understand this better. These machine readable in-network files. Tell me about it a little bit. What's going on here?
Yeah, sure. So just as a refresher for the transparency and coverage rules, and remember, there's really three pillars of federal transparency rules going on right now. There's the hospital price transparency rule, which hospitals still aren't following very well. There's the transparency and coverage rules for insurers that's rolling out kind of multi-year over the next 2 or 3 years. And then on top of that, you have surprise billing. But part of the important thing for self-insured entities under the transparency and coverage rules is these machine readable files, which ultimately are going to be almost like a employee kind of patient facing data set that allows everybody to look at in-network, out-of-network rates by certain claims, even like drug pricing, what their deductibles are, what they have remaining out of pocket for the year. But at the end of the day, for insurers, this means that they have to put up a ton of data as it relates to in and out of network rates. And one of the ongoing questions, just like it is for surprise billing, because, you know, believe it or not, federal regulators in Congress still continue to look at the healthcare system as black and white, in and out of network, right? So like they don't understand RBP, and when you explain it to them, they're like, well, this is complicated. We can't go down that rabbit hole. And so they continue to treat everything in and out of network. But as we continue to talk to them about kind of like alternative pricing models and RBP value-based models, really, one of the things that's just come out in the last couple of weeks, Gray, is some clarifying guidance out of the agencies when it comes to how RBP plans can need and should be calculating, quote, in-network rates, right? Because the question is, well, you know, RBP plans necessarily don't have a network. So how do you then put in for a patient what that in-network rate is. And so I think this new guidance from CMS is helpful, both for patients and for RBP plans, because it finally gives at least some guidance saying, look, if you are an RBP plan, and let's say you're using a multiplier of Medicare, you can, there's now understanding kind of space for you within that machine readable file context of how you put that in there even before a patient may go in for that care. So therefore, let's say a patient has an RBP plan, they go on that, this transparency and coverage kind of their patient site, they'll be able to see what their RBP plan pays as a percentage of Medicare relatively for that procedure claim before they go in. And so I think that's helpful. I think it's helpful that the agencies understand that RBP is part of that process and are allowing now for data and information to input, because there's no doubt they want that RBP information in there, even for in-network. And the last thing I'll say is I view that as helpful for some questions we still have remaining for the No Surprises Act and surprise billing, because I think that will, I think some of the agency understanding on the transparency and coverage rules will also then translate into some of the outstanding questions we have in the No Surprises Act and how RBP fits in there, considering that, there's a prohibition on, for instance, like the use of Medicare, but that doesn't necessarily translate into like the in-network median rates calculation. Right. So I view that as a very positive thing.
Yeah, I mean, as long as the one side of the government's talking to the other side, right?
Yeah. Well, and it's coming from the same agency, and so that's helpful. And it just depends on the rule. But the good thing is, moving forward, at least for transparency and coverage, RBP plans now have at least some clarity in how they can comply with that in-network rate for those employees and their dependents under the plan.
Well, I can tell you what, I have more clarity now after you explain that, because when I was looking at this, I was like, in network, wait a minute, we don't do that.
Right.
So that's
the question, right? So there's no network. So do we have to do anything? And I think that was one of the questions they got. So the answer is that, even if you don't have a quote network, you have to do almost like a good faith estimate under any type of plan, including RBP, about what that in-network rate could look like.
Awesome. Well, I think we should go to the final slide here before we go into questions, because it's already almost half past, and I do want to get into prescription drug pricing. Now, we do have a lot of questions coming through, folks. Be patient. We'll get to your questions. Heath's really good for that. So let's get into drug pricing. We're halfway to November, and I feel like with the midterm elections coming up, I always hear about prescription drug pricing, right? And I think the audience here wants to know more too. So are there legislative proposals on the table? Specifically, we're going to talk about insulin here, everyone. And is there some traction from Congress on this? Are we going to see some action? And again, we're looking at this cost of insulin example. I am completely floored. I mean, again, I've only been in the industry for a couple of years now. I'm starting to get it, but boy, United States, almost $100. Everybody else is anywhere between $6 and $14, unless you're an outlier like Turkey and you're only paying about $2.50. What is up with that? And are we going to get an insulin price cap this year, Ryan?
So, I used insulin just as it's a good example of what's kind of going on generally in the drug pricing space. And we all know this. I mean, look, drug expenditures and self-funded plans have skyrocketed over the last 10 or 15 years due to, some highly specific, orphan drugs, things like that. And I think that the cost of insulin has just, kind of going back to what I was talking about, surprise billing, has caught policymakers' attention, kind of like, the shortage of milk formula or baby formula, because the fact is that, there's a lot of people who depend on insulin for their day-to-day, health. And all of a sudden, when insulin prices go skyrocketing, all of a sudden policymakers pay attention, and they should, right? Okay. But it also goes to a larger issue at hand here about the cost of drugs. And when a drug comes out of a drug manufacturer, the big question is, well, how did you price that? Is there actually a legitimate reason for that? And we don't have the answers for it. going back to insulin, a number of states have capped the price of insulin to protect consumers in those states. Even right now, there's states like Louisiana who are actually doing have legislative proposals in the works during the current legislative session to cap insulin, and those are all fine. About a month ago, Gray, to this point though, the U.S. House of Representatives actually passed a federal bill that would cap insulin. I believe it was $25 a month per person, and the likelihood of that going in the Senate is probably fairly low. Just like some other proposals, and we can talk about that. But I think one of the issues at hand with insulin and any price capping is this, though. If you cap insulin, that protects the patient, but it doesn't do anything about solving the overarching issue of the actual cost of it. Because the fact is that a self-insured plan, if insulin's $300 and the patient only has to pay $25, somebody is still paying the $300 for insulin. And the problem that we have as Psy is that gives no, it doesn't give any reason for the drug manufacturer itself to not even take that $300 up to $500, because they're still getting paid no matter what happens. And so it's really a cost shift. And I think one of the big policy issues now is, look, we're all dedicated to reducing the price of especially needed drugs, but how can you do it without a cost shift? Because the fact is, if you have a cap on insulin like that, self-insured plans are still going to pay the $300 for it or whatever the negotiated price is. And it's just going to end up increasing the cost of that plan for everybody, rather than tackling the main issue, which is, why is Abbott or Pfizer or whoever charging $300 for insulin that a year ago was $75, right? And that goes for a lot of other drugs just outside of that insulin cap. But I do think it's interesting that the House passed it. Again, I think in the Senate there's more of those overarching issues about just the cost of drugs in general.
Huh. You and I talked about this the other day, Ryan. SIA released its drug pricing best practices guide earlier this year. What is up with that? Is it a resource people can use?
It is, hopefully. It's something that we actually began even before COVID. I remember our first in-person meeting a couple of months before COVID hit. But one of the reasons, and going back to the insulin example, that we went down the road of having this drug pricing kind of best practice guide for self-insured participants is that we felt like, everybody has a problem with the rising cost of drugs, but we are not going to get any solution from it from the federal government. So we need to take it upon ourselves as industry participants to at least have some guide to help do that ourselves. And so we brought together a group of different participants, stop loss carriers, employers, TPAs, brokers, and kind of went through the whole gamut of the drug pricing process in the self-insured world, and came out with this guide that hopefully people find helpful. It's, we made it as a checklist. So no matter where you stand in the process, there's some things that you can look at in this guidebook that if you're not doing, you should be, to help reduce at least the cost as much as within our power as self-insured kind of plan managers, if you will. And so it looks at, rebates. It looks at the roles and responsibilities of people in the process. And importantly, it also looks at plan docs, which should always be kind of these living, breathing documents that are that are up to date and also allow flexibility in looking and negotiating, looking at generic alternatives, step therapy, things like that. And I'll, the one caveat is that this drug pricing best practice is largely put together to look at drugs that were like $250,000 or higher. So like your very high cost drugs that really make a big financial impact on plans.
Well, listen, Ryan, do us a favor and send that out to our 6 Degrees Health people so we can include that in the follow-up in case our audience members want to get a link to that drug pricing best practices guide. Does that work?
Sure. Yeah. It's available to SIA members on our member resource portal. Yep.
Got you. Okay. So that is available to the SIA members. So consider being a SIA member, everyone. All right. So let's transition into the Q&A. Let's talk a little bit about what Ryan's been speaking to. And Heath Potter, everybody, I see you got your name changed.
Big day. Got my proper name on the screen. I'm sure Lindsay's happy not to have her name associated with my face. So.
No comment.
All right, we're going to the Q&A.
Yes, sir.
Excellent. I didn't really get to give my normal welcome Ryan speech in the beginning there because we were so fixated on getting my name correct, but it is a pleasure to have you on the Fireside Chat again, Mr. Work.
Thank you.
Being here. Yeah. All right, so we got a few questions coming in. Hopefully a few more come in as I'm asking these, but the first one that came in early was, will you cover let me see, I'm unsure if you'll cover this. So, okay, for the MRF, so the readable files, the regs state it must be posted on a public website. Can this be posted on a TPA website? Question one. Some of the TPAs are posting on their sites, but we have one who is not. Also, our employer is required to keep the archive of these files. Am I correct? The members will not be able to read these files.
Well, there's a couple of questions there. I don't know if it's, I mean, you want it on the a website, like on the plan website itself. Now, if the TPA is keeping that website for the plan, then I guess it could be up on the TPA website. Now, the machine readable file, it's going to serve a couple of purposes, but ultimately that machine readable files needs to be available so the public and probably like others can utilize it in like an open network kind of architecture plan. But there's another point in there about, well, will consumers ever really utilize the machine readable file? I think the point is that the agencies kind of want that patient facing website to have that data accessible so they can then determine what they could or may pay for claims in and out of network, what their out of pocket is and everything else. I think one of the main concerns with all of this is that we can provide as much data as the federal department. I mean, I don't want them to mandate all of it, but the fact is that we can put out all the data that they ask for, but that doesn't mean the consumer, one, understands it, or two, is ever going to utilize it. And so one of our big issues has always been, look, like we're all about price transparency. You also have to understand the administrative burden and the cost that this has on plans, vis-a-vis what is actually going to be helpful to the health plan consumer. And, as far as I'm concerned, one, we all need to do a better job of educating consumers about their healthcare. Like, it's just simple, right? And it's hard to do. But in some of that is consumers taking it upon themselves to find time to understand their insurance and their health benefits and everything else. But at the same time, I think a lot of this data that's going to be posted, is going to be above and beyond what a lot of consumers can actually understand. So there's some give and take on both sides. But my fear is, no matter what kind of data we put up, as helpful as that may be, at the end of the day, the question is that going to be as helpful as the federal regulators think it is?
Okay. Question number two. And I think you kind of hit on the fringes of this one, but I'll ask it again. What if a member has an out-of-network air ambulance claim and the IDR determines the amount over the plan benefit maximum? Example, plan benefit maximum is $25,000 and the IDR determines the amount to be $30,000. Therefore, the member is balance billed with a $5,000 additional. Is this acceptable under the NSA?
So one, air ambulance is treated differently, for instance, than like the ER and the out of network, right? So the payment determination is based on the complexity of the service provided, the type of aircraft it is, if it's rotating or fixed wing, as well as kind of like the geographic areas. Plan docs, the No Surprises Act, at least in the medical benefit side, and I have to look it up on the air ambulance, always, if the service, for instance, is like exempt. So I'll give this example, Heath. If I know of self-insured plans that don't cover air ambulance under their plan, in that case, no matter what the patient protection is, that they do not have to pay for air ambulance So for instance, if you have a self-insured plan that doesn't cover ambulance, you would not cover ambulance, right? It just, that's what it is. I'd have to, the air ambulance payment, I think the question is, what would the IDR look like if it was above the plan maximum for that specific plan? I guess it depends on how the arbiter reaches that. But I would say that the plan doc overrules anything, but I don't think the patient can be balance billed just because the plan doc says that they'll only pay for the first $30,000. I think it would probably protect the patient, and then the plan would have to negotiate with that air ambulance provider, but I'd have to check that out. One of the things that we've gotten into now that people are getting into the open negotiation, the IDR process, are a lot of nuanced questions pertaining to like the NSA, and then how it pertains to like specific plan document language, and if there's like exemptions and things like that that are creating, you know, some really interesting cases to look at vis-a-vis like where the rules are.
Okay. Okay. Next one, and you did kind of hit on this one as well, but how does this work if you do not have a network? I.e., we have open access for all providers and facilities.
Right, and we've kind of addressed that well in some past discussions, right? So, like, let's say you have an RBP plan, and this, you know, one, there's a lot of open questions on that, and we have not gotten to a final rule. So remember, we're operating right now under a number of interim final rules, and because all of the lawsuits going on by the providers in the surprise billing space, we will not have certainty on this for some time, and at this point, the federal agencies are hoping to come out with a final rule sometime in quote early summer. Now, a month ago, that was like, we were expecting a final rule in June. Now we're expecting an early summer. It's being pushed out because of the 7 provider lawsuits out there. I say that because in one of the interim final rules, there was a specific question, because they're open to public comments, on how the federal department should treat RBP, kind of going back to like, what if you don't have, you know, a network at all? So there's that, right? I guess I say all that because one, we're gonna get more clarity on that because there's questions. SIA right now is of the opinion that in some instances, the No Surprises Act actually doesn't touch RBP. So for instance, in an emergency situation, you know, you'll always be under NSA, but then that changes when in that second scenario, when you have an in-network facility with out-of-network providers. We're of the belief that that will actually never pertain to an RBP plan because you don't have a network with out-of-network providers. You're always out of network. So it really comes down to that first scenario, which is emergency services. And then if you don't have a network in that case, you go through the process, right? You go through perhaps a denial of payment. You go through that open negotiation process, and you can negotiate, like, let's say your plan pays 175% of Medicare, right? Well, then you can negotiate based on that rate and maybe past payments you've made for a similar or that type of claim code. And then if you don't come to an agreement there, then you go to arbitration. And I think that's where the concerning part is, like whether, you know, how you justify that versus the QPA, whether a provider is actually going to take that in the open negotiation process, and then how the IDRE, the independent dispute resolution process, you know, contact, if you will, the arbiter would deal with that. But we think that there's clear ways where RBP plans can come up with either a QPA based on their past claims, or perhaps more importantly through a database.
Okay. In terms of those QPA fees, who is responsible for paying those?
Oh, for the independent, like for the arbitration fees?
Yeah, I think that's a separate question. This one's for the QPA fees. I can kind of give you my spin on it, but I'd like to hear yours first.
So, well, there aren't. So I guess you need to clarify that, because the QPA is like a calculation of the in-network median rate, right? So who's going to pay that ultimately?
I think there's some folks out there that are charging for that today. We do not, but I think there are some doing that. So.
Well, I mean, there's no set process within the federal rulemaking about who is responsible. I mean, the fact is somebody within the plan has to calculate the QPA, right? Now, whether people within the like vendors or something are charging for that, that's beyond the federal process. The only fees included in the federal process are the fee, and then the fee to enter arbitration, and then ultimately if you lose, whoever loses arbitration pays the entirety of the arbitration process. So does that answer that question, Heath?
I think so, yeah.
Okay.
Where is the site to find the readable file? Price transparency is missing link. Members would love expected costs like a menu. Members request this info regularly.
Sorry, is the question about where you can find the machine readable files for plans?
Correct.
Yeah, so some of that's just not available yet because the rule is out in a number of different phases. I think the next part of the rule is like due in July of this year. So not all of that is there. It eventually, like by the end of 2023, you should be able to go on a plan website and find that in an MRF format, similar to like what hospitals should be doing today with their with their codes and their highest in and out of network rates in the hospital transparency rule. I think the question then is, will people actually do that on time? And two, will it be easily accessible on a plan website, and how long is that going to take? So I think it's going to be dependent on the plan, how transparent they are, where they place it. I mean, if it's any indication, we're 2 years out from the hospital price transparency rule, and while it's a different monster, we still don't have all those files accessible even after the due date for it.
Okay. During the resolution process, is the provider legally bound to negotiate on an NSA?
So technically, you are legally bound to go through the 30 business days of the open negotiation period, right? Now at the end of the day, you have to go through the 30 business days. You can't just fast forward and say, I don't want to negotiate, we're going to go straight into IDR. Like you have to, and whether it be in good faith or not, like you have to spend those 30 business days negotiating. If you don't want to negotiate, you still have to wait 30 business days to enter IDR. But the IDRE entity is going to know or will be advised whether there were kind of good faith negotiations going on, which could then kind of impact the IDR decision, if you will. But technically, no, you're not mandated to negotiate, but you still have to go through those 30 business days until you can then enter into the independent dispute resolution process.
What level of culpability does a health plan and or TPA with networks incur regarding the accuracy of whether providers are in network? This is in regards to the Consolidated Appropriations Act, directory accuracy, and are they updated every 90 days?
So the culpability of plans to make sure that their directory files are up to date, is that what the question is?
Yep.
Yeah, I mean, technically under the CA and even the TIC rules, and there potentially could be fines for not, for not having that up to date. But right now it's like a good faith. There's a lot of usage of good faith, but there's a good faith effort to ensure that those, like that in-network provider directory is up to date within that certain time period.
This one, back on the Q&A side here, several broker RFIs have come in our way as a direct stop loss writer asking how we'll handle claims paid under the NSA. For instance, if a known claim has some delayed payments after the contract period runs out that were known to be negotiated or arbitrated phase, how imperative is it stop loss carriers proactively address this concern?
So does that have to do with kind of like the long tail on stop loss claims?
Yep.
Yeah. So what I've been telling people is that it's going to be important for plans and their stop loss providers to make sure that there's flexibility in their plan documents to address that. Because remember, after let's say you go through the NSA and you go to arbitration, or even if you decide on a reimbursement, on a mutual reimbursement rate during open negotiation, you then have 30 business days to make that payment. Okay. And the other part about this, which makes it a little more difficult for stop loss, is because of all these different calendar days, and all of a sudden you could get a claim, but by the time you get through all these business days and calendar days, and even like the arbitration process, you could be months out, right? So you could have a claim that hits in October of one year, but you may not have a final determination until, maybe, February, March of the next. And so if the stop loss care needs to be involved in that, you have to make sure that the plan docs are flexible enough to, one, create that tail when it comes to like the surprise billing process, to accommodate that claim like well after the fact, because the NSA is pushing it out.
Okay. Gray, I'll turn it back over to you.
Awesome. Good stuff. Thank you so much, Ryan. We've still got a few more minutes. Is there anything else top of mind, Ryan, that you feel like you want to touch back on? I know we had to blast through some of those slides. What else is on your mind?
I think I'll go back. I mentioned it quickly, but I wanted to touch upon the lawsuits going on with surprise billing, because I think that they're, one way or another, they're going to impact the actual implementation of the No Surprises Act. So right now, there's 6 provider lawsuits against the NSA. Imagine like providers not wanting price transparency or patient protections. And then we have a new air ambulance lawsuit. But right now, like I said, there are 6 provider lawsuits against the NSA, one of which was in the Eastern District Court of Texas by the Texas Medical Association. The judge there was a former attorney for a hospital system, found in favor of the hospital or of the Texas Medical Association, in that the QPA cannot be the primary factor in arbitration, which basically what that means in short is that it would raise the cost of what a bill could possibly be. And that order was across the country. They vacated the initial federal rule. That judgment in Texas is now in place across the country until it goes through the appeals process, which is also why we're seeing a delay in the final rule. There's even a surgeon in New York City is actually fighting, the NSA on constitutional grounds, saying that he should be able to charge a patient whatever he wants to in a balanced bill. So with all that said, the American Medical Association, the American Hospital Association, others are dropping lawsuits all over the country. Those will have to play out. They did the same thing for the hospital transparency rule, but we've been fighting those with amicus briefs. And at the end of the day, the departments know that those are out there. They're fighting them. They're going to have to deal with those in a final rule, and then also oppose those in courts. But the important thing is that this could, even after a final rule, it could be a while until all those lawsuits and all the pieces are finally put in place to have some solidified clarification when it comes to NSA implementation.
Yeah, that's fascinating. I mean, it would make sense to me that there's some lawsuits popping up on this.
Right. And what the problem is that it for the time being, it could increase, our goal with surprise billing protections was actually to bring down the cost of care. The hospital lawsuits are trying to actually raise that because they want the most reimbursement they can out of it. But it's also prolonging an already complex and burdensome process. And so, we want to make that as short as possible. We want a final rule, and hopefully one that helps bring down that cost, that reimbursement measurement.
Yeah, I mean, the way I look at it, it's consumer protection. I mean, that's my perspective,
Right.
personal perspective.
Right.
Heath, is there something else you wanted to add?
Oh, I was just gonna say, it sounds like there's more to come, so I think you'll be coming back on the show here.
Yeah,
We
yeah.
will
There's
definitely
definitely. I
have
mean,
you back.
you know, I think overall, I've said this before. I mean, price transparency in general, whether it be the tick rules, whether it be hospital price transparency, whether it be surprise billing. I mean, we're on a multi-year road on that, right? And it's going to be a bumpy one. But hopefully, as we talk like 2-3 years from now, we'll be in a better place with more clarification and understanding. And kind of getting through these various implementation deadlines and complexities, but it's going to take some time to get there.
Well, listen, folks, let's wrap things up. I do want to thank Ryan and acknowledge on the next slide. Yep, boom. Here's Ryan, Senior Vice President, Government Relations at the Self-Insurance Institute of America, which is SIA. You can reach out to Ryan directly at ourwork@sia.com, sia.org. And then we also have Heath Potter here today. Heath Potter is the 6 Degrees Health Chief Growth Officer. And you can reach out to Heath Potter at 6degreeshealth.com. That is who I work for as well. We do have more fireside chats coming down the line, folks. So look for the registration details in an email. If you happen to want to rewatch this one or see the past 2 years of our webinars, go to 6degreeshealth.com/webinars, and you can find past webinars there. You can you can register for upcoming fireside chats as well. We totally appreciate you both. Ryan, you're coming back to see us, right, this fall?
I hope anytime.
Okay. Heath, great to see you. And folks, thank you so much for attending. We always enjoy the questions. If you have more questions, feel free to reach out via the emails that I just disclosed. Glenn Kelly says, very informative. Thank you very much. Claire Wood says, thank you. Excellent discussion. I'm stoked as well. Thank you very much from Portland, Oregon. We'll see you at the next fireside chat, folks.
Thanks, everybody.
Thanks.
Thank you, Ryan. Appreciate it.
Bye, everyone.